Good morning and welcome back to day 2 of the 30th Annual Canadian Conference on HIV/AIDS Research. Yesterday, we enjoyed a stellar program and hope you were able to join us. As a reminder, all presentations will be available on demand viewing within this platform and on CAHR's YouTube channel after the conference. Today, please take some time to visit the sponsor gallery to see what is new and exciting. Please also set aside some time to visit the poster gallery. You can view the posters at any time on demand. Also enjoy the opportunity to ask the poster authors questions about their exciting work. Later today, the CAHR Annual General Meeting takes place at 5:45 p.m. Please be sure to join us. And now we begin day 2 with the Social Sciences Keynote Presentation by Ruth Cameron. Enjoy the day.
Welcome to the Social Science Track Plenary. I'm Dr. Eli Manning. Dr. Cian Wilson and I are the Social Science Track Chairs for this year's CAHR Conference, and we are honored to have Ruth Cameron presenting this talk today. Ruth is a PhD student at Wilfrid Laurier University in Community Psychology, as well as the Executive Director for the AIDS Committee of Cambridge, Kitchener, Waterloo, and area. She is also a member of the Ontario Advisory Committee on HIV and AIDS. Ruth's intersectoral health equity work engages intersectionality as a framework for systems-level interventions in health equity. Ruth's session title is entitled Reality Check, Considerations for Community-Based Research. We hope you find her talk today insightful and challenging, as well as thought-provoking and engaging.
Good day. I want to start my talk today by thanking Dr. Cian Wilson, who's an associate professor at Wilfrid Laurier University, for putting my name forward for this discussion, and the Canadian Association for HIV Research for agreeing to my keynote presentation. What I hope to do today is to raise awareness and sensitivity, perhaps, to several considerations which can be taken or observed as social scientists who engage in community-based research prior to approaching community-based HIV/AIDS organizations to participate in research. The considerations I'm intending to put forward are both pragmatic and practical issues, as well as some more theoretical reflections. Secondly, because I am a Black lesbian feminist, I want to socially locate myself for you to understand why I'm doing this talk in this manner and why I'm doing it at all. So at this point, you know that my name is Ruth Cameron and that I'm the Executive Director of ACCKWA, which stands for the AIDS Committee of Cambridge, Kitchener, Waterloo, and area. I'm also a doctoral student at Wilfrid Laurier University in Waterloo, Ontario. In addition to these roles, I work as a consultant focused on strategic planning and anti-oppression organizational development and change management. As someone who's trained in political science, sociology, and community psychology, and as an individual who has worked in both clinical and community-based research and in nonprofit organizations for decades, as someone who has volunteered and done some organizing related to health equity, ending anti-Black racism and queer rights, I think in very serious and intentional ways about the root causes that are the social drivers of HIV. Because of this social location and my employment, I try to innovate through the intervention that is the HIV/AIDS community-based organization. I hope that your social sciences research lens will help me in this regard with low cost and costed interventions. Intervention research assessed in terms of feasibility, resources needed for successful adoption, and economic impact. And that can be implemented sustainably within this service environment. Now that I've asked you for your research support, I'm going to qualify my request through 3 specific asks. I definitely have an agenda. First, I'd like to ask you to also think of ACCKWA as an intervention created by community. If you can think of the HIV/AIDS community-based organization as an intervention, how can your research fit or suit the strategic objectives, the mandate, and program structure of a community-based organization. Can you think of the ASO as a model or as a case study for case study research? The question then leads into a focus on implementation science and intersectoral health equity initiatives. Your evidence-based interventions developed through an implementation science, implementation research, or operations research approach have a much higher chance of being adopted with high accuracy and utilized to significant impact when they're pragmatic and feasible in the ASO environment. Getting to this level of pragmatism requires a reality check or a discussion of the operational context for many HIV/AIDS community-based organizations. I'll expand on this point by highlighting that additionally, many HIV/AIDS organizations are challenged in trying to establish some form of coordinated care continuum within their operation or regional care continuum within the geography of their catchment area. Research that is explicitly linked to the HIV treatment Cascade tool, in particular, to health initiatives in provincial and territorial health ministries could help us improve the HIV/AIDS service organization. Lastly, I'd like to discuss the choice and applicability of critical approaches to social sciences research and the frameworks we bring to research, as well as the unit of study. We need to consider whether the theory and frameworks we employ further obscure or reveal the oppressive mechanisms that are the structural and social drivers of HIV. I need to say something about how, in particular, intersectionality has been taken up in HIV social sciences research. Absent of specific key components or core facets of Black feminist thought that would require a fundamental shift in focus and perspective for much of our social sciences work. So, what is ACCKWA? ACCKWA is the AIDS Committee, again, of Cambridge, Kitchener, Waterloo, and area. We've been providing services in Waterloo region for 35 years, since 1985. We support individuals who are living with HIV and hepatitis C and related infections. We also support individuals who are experiencing challenges related to drug use, the opioid overdose epidemic, the impact of methamphetamines, and the poison drug supply. What should you understand from this slide? From my frame of reference, you should understand that HIV/AIDS organizations didn't come about due to goodwill, but from my frame of reference, you should also consider reframing protests and advocacy as one of the most impactful evidence-based interventions in the scope of HIV research. Much of what currently exists in HIV/AIDS service organizations, the research industrial complex, international, national, provincial, and strategic mandates and funding bodies would not exist without the protests and insistence on responsibility for extension of the welfare state to individuals. This activism resulted in a small expansion in the 1980s and 1990s within certain services and supports to include services for the communities placed at most risk for HIV by neoliberal state policy. As we did the work over several years, we noticed a series of stunning coincidences in moving from palliation, mutual aid, and education to ART medication access, population-specific prevention initiatives, and PrEP. Our organizations became less grassroots and more formalized and bureaucratized, with an expectation that we would provide services to service users through coordinated service access to a range of health promotion, primary, secondary, and tertiary prevention programs without being adequately resourced to do so. This paradox or conundrum has significant influence on the type of interventions we can implement sustainably in our organizational context. I believe that participant observation, methods in research, realist evaluation, and case study research are necessary preliminary steps before further HIV implementation science research. I have yet to see a body of social sciences research or literature on the HIV/AIDS organization, and I believe deep knowledge of these organizations could be fundamental to facilitating changes in HIV-related health outcomes for the communities at most risk for and living with HIV. Prior to the pandemic, Like other organizations focused on this important work, staff and programs at ACCKWA were focused on a mandate that involved population-specific primary prevention-focused programs, support programs focused on secondary and tertiary prevention, and navigating barriers related to the social determinants of health. We work towards the UNAIDS goal of zero new HIV infections through providing opportunities for peer empowerment and leadership, increasing awareness through education, reducing risk through providing free and accessible clinical, safer sex overdose prevention, and harm reduction supplies. Currently, at our organization, we support over 500 individuals and families that are directly impacted by HIV. I'm going to pause for a second and just allow people to scan our vision and our mission. Now, while I don't think it's going to light the world on fire, it is a mandate that is actually embedded in evidence that we use in our sector. It is derived from UNAIDS goals, evidence from the World AIDS Organization, evidence from our Ontario Provincial HIV Strategic Plan until 2026, as well as the logic model used to guide HIV/AIDS projects that are funded at the federal level through the Public Health Agency of Canada. Understand that when we are talking about working towards a future where HIV, hepatitis C, sexually transmitted and bloodborne infections, and the opioid overdose crisis are rare, that we are, as community-based organizations, talking about doing the best that we can with the resources that we have towards an elimination strategy, and making sure that individuals who are impacted and living with HIV and other STBBIs are experiencing optimal health in the most holistic sense, and well-being and full community participation, i.e. not experiencing barriers to service access and stigma in their lives. When we talk about focusing on key populations that we mentioned and providing excellent care, we're trying to follow current evidence that is discussed within our sector, however not operationally funded. And yes, in Ontario, we have been asked to implement coordinated service pathways without being given any resources to create new services. I want to talk a little bit more about our current state. So prior to COVID, many organizations which provide some aspect of harm reduction and outreach services were already significantly under-resourced in supports for people who use drugs. Understand that organizations like this across the country punch far above our weight, but we are at a breaking point. For the organization I run, we are in a region that has a population between 500,000 and 600,000 individuals, where we are supporting over 500 individuals and families living with or impacted by HIV. In total, we have gone from 12 staff prior to COVID and a team of 6 to 10 peers engaging with over 5,000 unique individuals in anywhere from 18 to 20,000 interactions annually, to 16 staff due to the growing inequality and exacerbation of needs during COVID. We operate in 3 fixed locations, 3 cities and 4 townships across 2 separate health regions in Ontario. As an organization that has 5 separate unfunded clinics focused on PrEP, primary care, HIV care, HIV STI testing, and psychiatric care, clinics that were solely resourced through partnership agreements, we lost 3 on-site clinics in COVID, while the number of fatal overdoses rose over 60% year to year in our region. This is the service context you are approaching when you ask us to participate in research during the pandemic. At a time like this, we will still participate in research if it is timely, sensitive, and relevant to the business of keeping people safer from potentially fatal overdose, keeping them housed, keeping them fed, keeping them connected and aware of their HIV status. One staff member of ours participated in a rapid safer supply study during the second wave of the pandemic, and findings and recommendations are being disseminated right now in wave 3. We will not, however, at this time, engage with research requests that will only be of use to our most privileged and our most resourced service users who have more minimal health concerns, substantial supports, and have reliable smartphone technology or internet access. I'm going to pause here and go a little bit off script regarding the focus of my talk. The impact of COVID has meant many things at our organization. Lockdown 1 meant the loss of a satellite location. It meant having to advocate for access to showers and washrooms for people who are homeless, reminding decision makers of the hepatitis outbreak that happened 2 years ago due to lack of washroom access. It meant having to provide support to individuals who were, needless to say, very concerned and triggered, having lived through the mid-1990s, the worst years in terms of losses of loved ones to the HIV/AIDS crisis. And these individuals were wondering what implications COVID might or would have for them, for the people they cared about, and what uncertainty it would bring. It also meant having to re-engage with forms of mutual aid that perhaps had been not thought of or engaged with deliberately or intentionally for quite some time. It meant having to move our programming, which we really rely on being able to tailor, being able to individualize, involving significant in-person contact with individuals, having to move that online, and therefore creating a digital divide between service users who have reliable internet access and those who do not. It meant having to reactivate a phone tree, a tool that we don't necessarily engage with as often anymore. It meant trying to actually find individuals who were so cut off from services due to homelessness and the lockdown that happened in the first wave that we had to go and check on whether people were alive, whether people were safe, and ask community members who were homeless to help locate other homeless community members. It meant having to advocate with regional government and work with many other great community partners to create a community service hub in a regional building. And that was necessary because in our city, in one city in our region, the community was so hostile to any services related to harm reduction for drug users and for people in encampments that a new space had to be found that was physically safe to provide the bare minimum of services. Needless to say, these types of developments and the overlay of all these types of developments onto the other gaps and cracks and the leanness of our healthcare, human services, community services, and social services systems illuminated much of what was already precarious through the lens of COVID, further exposing gaps that we knew existed for clients who were impacted by HIV and other social determinants. Prior to the pandemic, HIV/AIDS organizations were supporting individuals who were impacted by what we often call HIV, sexually transmitted diseases, and bloodborne infections. When we talk about HIV and hepatitis C this way, this focus on diseases rather than structures truly obscures the structures and the social determinants focus of our work, which is not supported adequately through any kind of expanded, functioning, or modernized Canada Health Act legislation, effective provincial and territorial welfare programs, disability supports policy, or sustainable affordable housing, and rent control models in the jurisdictions of what we now call Canada. Please, I'm asking you in your social sciences research to shift your research gaze to include scrutiny of these gaps and structures rather than essentially facilitating us to potentially gaslight our service users with programming focused on self-care, empowerment, and self-efficacy when structures are actively harmful to individual well-being and survival. Our organizations are spending considerable time and effort focusing on fundraising to bridge these considerable gaps, and that is time that we could be spending focusing on the provision of healthcare, social and community services to serve our service users. As social scientists, I want to pause here and say that in terms of your research, at one time, I too was a master's student in sociology and did a qualitative narrative study that focused on the lived experience of a group of individuals and tried to identify barriers and facilitators to service access. I'm not sure as an executive director that I need to see another one of these studies again. It's not that these studies are a problem, but in the larger social context of scarcity, I will say again that we need to place significant research attention on the root causes of that scarcity. I welcome your research interrogating our AIDS service organizations, or ASOs, and why they haven't become fully valued integrated system partners within the healthcare systems where they are located. I welcome studies on the potential economic impact of health systems integration and healthcare expansion measures. These types of studies will help us in our overall focus around HIV elimination, around getting to zero, around focusing on optimal health, zero stigma, and zero discrimination for people living with HIV, and people in all of the communities that we engage with in our work. Next, I want to talk briefly about tools that I found particularly helpful in shaping our work that happens at the organization I work at. I want to talk about the Treatment Action Group's Double Helix model, which looks at integrated service delivery for healthcare and social services, and really tries to think about the HIV/AIDS organization as a service hub. This is a physical space where we can allow for engagement of both individuals who are HIV negative and HIV positive. We're talking about engagement across the lifespan into our services and seamless transition for individuals, regardless of status, into the into the supports that the individual feels that they need at a particular life stage. What I want to focus on here is that this integrated service delivery model is something that has been talked about in many jurisdictions as the way to go with regards to the delivery of services for individuals who are at heightened risk for HIV and related issues. However, there has not been an attempt, as far as I'm aware, in any jurisdiction in Canada to provide any operational resources to embed this type of delivery model as a stable, durable standard of care or service in HIV community-based organizations across the country. I think it would be very important to research this and assess what level of development or implementation exists for this model between and across regions. What are the barriers and facilitators to implementing a standard for the delivery of integrated services? I think that aspects of this model exist in many organizations, and some may have something that looks very similar to this within their walls. But few organizations have each and every component of this model as a part of service delivery. I'd mentioned that earlier, prior to the pandemic, that we had a model where we had 3 different support focus programs, 5 prevention programs, and 5 separate clinics operating at ACCKWA that were focused on mental health, PrEP, primary care, HIV testing, STI testing, and HIV infectious disease care, all operating at our organization. Because they were, there was not an operational underpinning in terms of funding and resources for this, and they were done through collaborative partnerships, some of these clinics had to change modalities or fell away in the first wave of the COVID pandemic. Delegating the task of trying to create this integrated service delivery model to organizations that are not resourced to deliver these types of programs with consistency is not sustainable. And we need research supports that will help us in our advocacy to figure out sustainable ways of implementing these types of interventions, which can help us in achieving our goals related to the HIV treatment cascade and care continuum. In terms of other aspects of pragmatic research, the next thing that I want to discuss is our treatment cascade in Canada. When we look at our treatment cascade, something I can do at my organization is look at existing programming and think about how it assists with the goals of engaging and identifying the individuals who are unaware of their HIV status and that are living with HIV but not yet diagnosed, and showing up in the first bar of our treatment cascade, and how it helps us provide and focus on an array of services which may be of interest to individuals who are considering testing to improve the number of individuals who've been diagnosed with HIV and who are looking for means and mechanisms to learn about coping and successfully staying on treatment, and therefore show up in the third bar of our treatment cascade. And then how I can provide secondary and tertiary prevention focused programming across key populations to improve overall numbers of individuals who are experiencing viral suppression so that more individuals show up in the final bar of the treatment cascade. Again, in approaching and engaging with community-based HIV/AIDS organizations, something that I think helps us in terms of considering research engagement is whether or not the research you are considering can be both valuable to you as a social sciences researcher and also help us in terms of achieving our goals vis-a-vis the HIV treatment cascade. Can you pin your research or aspects of your overall research program to these bars in the treatment cascade? If so, that may provide us a shorthand for engaging in conversations and collaborations towards more community-based research. Next, I want to talk more freely and at length about some of the current realities that are a part of our work within the sector. And in doing that, I'm going to discuss what appears within the array of research and falls under social sciences community-based research within the sector, but also what does not, and some observations and reflections on or in this area. The first thing that I'm thinking about is the concept of the viral underclass. Rather than thinking about individuals within our sector solely through an epidemiological lens, where we are thinking about individuals vis-a-vis their connection to an array of interconnected diseases and conditions, the viral underclass is a concept that really helps us think through the structural social determinants that are actual true drivers of HIV and related conditions. In thinking conceptually about the structural oppressions and the material conditions experienced by the populations we work with and those that we belong to or become assigned to, then we can think about other things such as processes of racialization, of being classed and experiencing oppression as being identified as working class or as being experiencing being structurally disadvantaged and impoverished, being gendered and experiencing homophobia, transphobia, and sexism, experiencing anti-Black racism due to being descendants and diaspora through colonization and the ongoing violence of the transatlantic slave trade. And we can think about who is assigned the status of being non-human in racial capitalism. And we start to think more broadly about the connections between the interventions and the research we do in HIV/AIDS social sciences research, and whether that work actually reveals, covers up, or compounds the oppressions that are the actual drivers of HIV rather than behavior. Something that I see as being equally connected here is the strange absence or lack of an overarching anti-racism, anti-oppression analysis in our work when it comes to social sciences research that engages critical approaches or in our analysis of the conditions fostering the onset of HIV and a subsequent analysis of all the material conditions that are connected to being part of the viral underclass. In doing so, we would have to study the impact of the transatlantic slave trade. We would have to study the impact of our climate crisis as beginning through the environmental degradation that is integral to colonialism and colonization. We would have to study, perhaps looking at our policy choices, the social conditions that currently exist under neoliberalism as drivers equally in the current conditions for people living with HIV. This, in this analysis, it implicates us as having to perhaps study the dismantling of the remnants of our welfare state, rather than focusing on locating the problems in the individual or further examining the individual experience, when we already know the kinds of insults and injuries it can entail for those among the most marginalized within our sector and the service users that we can provide less services to. And we can then consider what we can remedy, retrench, and implement through comprehensive rather than piecemeal policy, through practice, and also through engagement in social movements and advocacy to bring about better material conditions for those who are most impacted by the HIV/AIDS crisis. This perspective would require an acknowledgement of social movements, of mutual aid, of activism and advocacy, of Black Lives Matter as interventions created by individuals who are part of the viral underclass to improve their own circumstances. And we would have to acknowledge that a focus on policing, carceral systems, and increasing widening inequality is a part of our work as researchers in the HIV sector. From here, it stands to reason that we would have to start to look at how we adapt and appropriate theory that focuses on these types of issues. There is a current understanding of our work in the HIV/AIDS sector that we are adapting and engaging in theory and in critical practice that engages with Black feminist thought, with critical race perspectives, critical disability studies, and that there is a validity to the way that we are adopting these theories in our sector. And I would challenge us to think more deeply and say that there is not that validity and that we consistently engage with partial adaptations of these theories and frameworks that strips them of their radical origins. The research that we engage in is far too often an extension of the colonial enterprise. If I use the example of Black feminist thought and intersectionality as illustrated, for example, through the Combahee River Collective Statement, it has not been adopted in an accurate way in our sector. In our work, we often use intersectionality to say that we are currently engaging in critical analysis when we are currently looking at complex intersecting oppressions and privilege that individuals experience simultaneously, both at the micro or individual level, and perhaps also at the meso level, sociologist, and at the macro level. However, we also at the same time fail to look at implications for our social sciences HIV research and for our community work when it comes to social democracy, the welfare state, and economic policy. Intersectionality and Black feminist thought, for example, mandates that this personal political connection through linkage of identity politics to material conditions that can only be relieved through action and transformative change is centralized. Delinking these fundamental radical components in HIV social sciences research that engages with intersectionality distances us from our goals related to service engagement, HIV elimination, viral suppression, getting to zero, and holistic health across the lifespan for the most complexly marginalized individuals and communities within our work that are living with HIV and are part of the viral underclass. To further advance what we are doing in research, how we hope to have impact on health and well-being for people living with HIV, how we hope to eliminate new infections through interventions developed through research and community services and advocacy. We need to think more intentionally about how we will engage alongside organizations that were built and forged through activism and advocacy. And we need to think about practice that will engage with community-based organizations to see what's happening around them with regards to the Black Lives Matter movement, disability justice movements, queer rights, and other social movements to bring about sustainable, durable change for the people that we work with. Something that I think about in all of this very deliberately is an example that is derived from the work that Dr. Ronaldo Walcott has done, writing on the state of sociology. In that work, he talks about the positionality of Black people in the academy as committing a crime, that our acquisition of knowledge, and note that I said knowledge, not wisdom, knowledge that is valued by white people has been made problematic. While Dr. Walcott speaks of all Black people in educational institutions, I would hone in on Black researchers and Black thought that interrogates white stream framings and researches social problems, like much of HIV social sciences research. The non-belonging of Black people as centered in this work demonstrates the partial views of European world understandings, and especially highlights how anti-Blackness is foundational to these European and white supremacist partial views of the world. And in short, Black people's questions, participation, and presence show up and call into question white supremacist and Eurocentric logics of the world, and place their violent biases on prominent display for all who actually to see. We know we can extend this argument across axes of oppression because of the utility and the universality, the queerness, the disability perspectives within the canon of Black feminist thought. Please research this, your perspective and your starting point, your standpoint for your inquiry. If you claim that you want to end HIV, research this and generate interventions that challenge the defunding of the very lives of the viral underclass. None of the interventions that you have diligently researched and care to see implemented can work effectively to high impact or to great effect in an organization that is grappling with rapidly increasing inequality, disintegration of departments of public health, and dismantling of Medicare during COVID. Research this political moment. Please also research expanded universal health care. Far too often, when I'm approached for research, the framing of the research approach, the perspective engaged in is absent of the people in that first bar on the treatment cascade. And the individuals we claim are lost to follow up at each stage of the treatment cascade. Black people are not seen as experts or as advocates in this research enterprise, but as data. Again, I must thank Dr. Walcott for this thinking. Rather than being seen and centered as experts due to analysis of the processes engaged in the complex marginalization that results in HIV, we are often seen as valuable in providing data to the researchers in terms of how they want to engage with our organizations. We will stay here dealing with HIV, dealing with the ongoing and lingering and further evolving impacts of COVID into our communities long after, much like HIV, the mainstream or the white stream says that these issues are over. When capital says these issues are over, when capital says concerns, epidemics, syndemics, pandemics, when the academy says it's over. If we are to truly engage in progress or transformation with regards to meeting our goals related to the treatment cascade, we will need to further our analysis and start to very intentionally engage in a non-appropriative way with the complex ideas, fully intact theory, and expertise embedded in the communities placed at most risk for HIV, placed at risk through organized state government abandonment, to bring about a future where an expansion of services and expansion of the welfare state, basic income, and pharmacare are part of our HIV response, supported by solid HIV social sciences research. We cannot go on as we are currently operating. I thank you for your time and hope that you have questions for me about how we can move forward in a deliberate, long-term community research partnership for a future where research is engaged to bring about elimination of the conditions that allow for widespread transmission of HIV and COVID for the communities that are facing the most severe and compounded oppressions and placed at greatest risk for HIV, state violence, COVID-19, morbidity, and mortality. Thank you.